Perfect. Okay, thank you. Good morning, good afternoon, good evening, clinical problem solvers. Nice to see everyone. Sorry for our delayed start today. We have a neurology case from Tansu and would love to have two discussants, ideally one discussant identifying as a woman and one identifying as a man. Anyone excited to discuss a neurology case today? Yes, thank you, Yasmin. I know you've discussed several, so we'll keep you as here in the possibility space until we have some other folks who maybe haven't discussed with us before. Anyone? Yeah, and Sridhara, you are also a frequent discussant, so we're happy to discuss with you, but anyone else? Anyone had been waiting to discuss a neurology case? Anyone? Tansu, maybe you can introduce yourself and where you're going to be presenting to us from and what stage of your training, and maybe that will inspire some people to want to discuss your case.
Sure. My name is Tansu. I'm an international medical graduate from Istanbul, Turkey. I'm currently residing in New York City, and I'm connecting right now from an office room in Mount Sinai Hospital. I'm doing a research here, and I'm applying in this cycle for internal medicine, but I love neurology too, so I brought this case to you. I didn't see the case myself. A friend of mine, a neurologist friend of mine, who is working in the UK, gave me the case. So I'll be presenting a case that she saw.
Fantastic. Looking forward to it. Okay, any volunteers? We often have the same discussants every time, which is fun for continuity of clinical problem solving, but it would be good to have some other people have a chance. Anyone? Anyone want to discuss a case? Anyone? Going once, going twice. Same discussants as previously. All right, Yasmin and Sridhara, you're up as per prior sessions. Hopefully you'll inspire some people to want to volunteer next time. Go ahead and introduce yourselves and we'll go ahead and get started.
Okay, I think I can begin. Like, if nobody is volunteering, I guess like we can end neurophobia today. Well, I'm Jasmine. I am IMG from Mexico, and I'm very happy to be again discussing.
And I'm Shri. I'm one of the vascular neurology professors from Thomas Jefferson in Philly.
Fantastic. Okay. Why don't you go ahead, Tansu, and tell us the chief concern?
It's muscle spasms, the chief concern today.
Muscle spasms. Okay. Yasmin or Sridhara, where would you start with muscle spasms?
Go ahead, Yasmin.
Okay, maybe I can begin with it. When I listen to muscle spasms, before going to a very specific diagnosis, the first thing I will look for is electrolyte. Like, by the way, just a question. The patient is young or?
We'll find out. Yeah.
Oh, okay. Muscle spasm. Well, in any patient without thinking if it's a male, female, or age, I will look for electrolytes. That's the first thing I would think. Or if there is an issue with calcium, if there is issue with sodium, or even with potassium. So that will be the first thing I would look for. And if the patient is dehydrated, or if the patient was exposed to toxins, that would be like, if this is in an acute setting. If these were like chronic, I will look for something more systemic. But that's my approach to it. What do you think, Dr. Aaron and Dr. Sridhara?
Yeah, Great initial points here. As with any chief concern in neurology, we have to wonder, is this a primary neurologic disease causing the symptom, or is this a medical disease that could cause a neurologic symptom? So we would think about that for anything from altered mental status in the brain to spasms of the muscle. So a great point is there electrolyte disturbance, which can cause muscle spasm. Thinking along those lines of, could there be a medical etiology here? Sridhara, what were you thinking here?
So great points. When I think of muscle spasms, common things being common, like Yasmin mentioned, and you mentioned, medical conditions and, electrolyte issues are very common. The other thing I'm thinking
Oh, we
about
lost you,
is it,
Sridhara.
oh, can you hear me now?
Yeah.
Uh, is it local or is it generalized? Local, you're thinking, okay, is there an injury or is there something else going on focally that's causing local muscle spasms? The time course. And also, I always want to clarify with patients what they mean by muscle spasms, because to patients, muscle spasms can mean muscle weakness, it can mean other things. Or it could sometimes mean sensory issues, which may not have nothing to do with the muscle itself.
Yeah, what are some of those things that could be called muscle spasm? That's one of the directions I was going to go in, but I'll ask you, Sridhara, that could be called spasm by the patient, but what do you think the possible differential diagnosis for the actual neurologic phenomenon could be?
So radicular pain, sometimes when they have the shooting pain in the leg, patients describe them as muscle spasms. I've seen that happen a lot in clinic. And sometimes, a focal soft, either joint pain or like a Baker's cyst or other things that don't have to do with the muscle itself. Sometimes patients describe that as muscle stiffness or muscle spasm.
Yeah, great point. So we're going to want to understand from the patient what the spasm is, but I always like to pause on this and just to get a sense of what's going through everyone's mind. So if the patient is saying muscle spasm, is it truly a cramp or a spasm of the muscle itself, or is it radicular pain, as Sridhara said? So what are some things that could cause the muscle to, let's say, move spontaneously? So maybe it's just individual muscle fibers and fasciculations, although those are usually not going to move the muscle very much, just along particular fibers you can see moving. So probably patient wouldn't say spasm or cramp for fasciculations. Could it be a true muscle cramp, which could be seen in muscle disease or in peripheral nerve hyperexcitability syndromes, which are quite rare, so we won't go down that rabbit hole unless that becomes relevant later on. Could the patient actually be experiencing spasticity and using spasm the same way we might use that same root spasticity from some type of upper motor neuron problem? Could the patient be having focal seizures that are causing the muscles to contract and go into some type of posture that, if it's focal, such that the patient's maintaining awareness, they may observe that? Or is it some type of dystonic spasm, so dystonia or movement disorder? So it's a general chief concern, and we'll want to have some idea in our minds that this could be anything from seizure to movement disorder to some spasticity to some peripheral process of the muscle or nerve. So with those in mind, we'd want to get some of the history that I know Yasmin was asking about. And so let's hear a little bit more about the age, context, and what muscle spasm means to the patient. If then there's associated pain, as Sridhara asked, sensory changes, weakness, or otherwise.
Great thoughts, great thoughts. So our patient is a 54-year-old woman, and over the past 10 years, she had fluctuating painful muscle spasms, sometimes lasting more than half an hour to hours and days, and occurring multiple times a day, and then improving. And those spasms were accompanied by jerks, axial and limb stiffness, prominent on the left lower extremity, and variable stiffness in the left upper extremity. Her spasms became more frequent over time, and she started falling, and this necessitated hospital admissions on several occasions. I'll just stop here.
Okay, great. Sridhara, Yasmin, what does this additional history suggest as far as what are these muscle spasms and what types of conditions might you be thinking about, or what other information would you want to ask Tansu?
I think I can tackle this first and then Shidara. And I think that when I'm listening that this for the past 10 years, thinking of something obviously more chronic, which could be a demyelinating disease, or in like I'm trying to get into obviously try to not just anchor on autoimmune disease, but this time onset, the is a 54-year-old woman and the accompanied by jerks. I would also want to know like if it's localized in only one muscle, one group of muscles, which is very difficult, I know. But then maybe I would definitely think what can we look in the electromyogram and electromyography, sorry, and if there is also weakness. I'm not sure like if this was if it was accompanied by weakness, but I will definitely want to know if there is a demyelinating disease in front of us. What do you think, Dr. Sidara?
Very good points, Jasmine. So I'm hearing the course and I'm looking at the patient's age and that she's a woman. So you always want to think about this in the form of are there any conditions that are more common at a certain age and at a certain duration? Uh, what I did here was there was some axial and limb stiffness, and that with muscle spasms definitely makes me think of stiff persons, which is an autoimmune condition which sometimes goes undiagnosed for a long period of time. And like I said, we do want to clarify what the meaning of muscle spasms is, um, because muscle pain can often be confused for muscle spasm, and a lot of metabolic myopathies can present at an older age with muscle pain that comes and goes, especially it might be related to exertion, might be related to carb loading or other things. And the patients they complain of muscle pains in axial and lower limbs, and then it improves. So two things that definitely come to mind. I'm not hearing other localizations. I'm not hearing sensory symptoms. I'm not hearing um, bladder or bowel symptoms that make me think of the spinal cord. And I'm not hearing any cognitive symptoms, any cranial nerves, anything else that makes me think of other localizations at this point.
Yeah, great discussion, both of you. So we are hearing spasm probably in its literal sense, right? That the muscle is going to some type of spasm based on the patient's description, that the muscles are becoming stiff and painful, and that is sort of episodic and fluctuating. It's a good point, Sridhar, to think about. You, yeah, a lot of things you said were good points. So one is, would you think about this condition, stiff person syndrome, and we'll talk about that more in a moment. But the question of whether we want to still keep a little bit more of an open mind about what is meant by muscle spasm and whether the muscles themselves are painful rather than true spasm, and whether that could be related to some type of primary muscle disorder. It sounds like here it's true spasm, and it's accompanied by these jerks. What do jerks make you think of in terms of neurologic terminology, Sridhara or Yasmin?
Shock-like muscle movements always make me think of myoclonus in the differential.
Yeah, so myoclonus. So we're getting a general sense of sort of hyperexcitability here, right? That there is muscle stiffness and there is myoclonus. So I agree with you. One condition we would want to think about here is called stiff person syndrome. Do you or Yasmin want to talk a little bit more about that and how this history led you to begin thinking about that?
Of course, where stiff person syndrome, I think that's a very good differential diagnosis, because we're talking about this is a progressive issue. There is muscle stiffness plus rigidity plus spasms. And it says that it's only left side, so I'm guessing, an axial. So it can present that way. And it's also, although we don't know a little bit more about her gait, and other, if there are triggers, and so maybe we will get it from Tansu afterwards. That will be listening about those symptoms in this patient can point us to stiff person syndrome. Although we will also need to see if there are anti-GAD antibodies, if there are oligoclonal bands in the CSF, also EMG studies, but we can keep it on the diagnosis, differential diagnosis.
Yeah, excellent.
Yeah, all
Just,
very.
yeah, go ahead. Yeah.
I was going to say all very good points. The one thing that draws the history towards stiff person is the fact that it started in the axial and the limbs, which usually it starts in the lower back. Many times when we see these patients in clinic, we see exaggerated lumbar lordosis. And other than that, there might not be much in the way of physical exam. So often these patients get diagnosed with functional neurological disorders or chronic back pain. They get a lot of medications before they see a neurologist and the diagnosis is made. And other than GAD, there are a few antibodies. I think amphiphysin and DPPX, and then I think glycine. And this happens because of the hyperexcitability from glycine. And these patients can have other features too, like ataxia or vestibulopathy, and even like cognitive impairment, encephalomyelitis with hyperexcitability. And I think the good point is about the EMG, which hopefully we'll see in this case, and the treatment. We can talk about that.
Yeah, brilliant points by both of you. So this is a condition that's relatively uncommon and so not known really outside of neurology in many cases. And so as you both said, these patients can be misdiagnosed for years because the symptoms may seem early on out of proportion to the signs. A lot of people have back pain. This could be severe back pain due to severe spasm of the axial muscles. And as Sridhara said, you can sometimes even put your hands on the muscles and feel the degree of spasm, but also there's so much spasm that it pulls on the spine in such a way that it exaggerates the lumbar lordosis, and then that can progress to the limbs. And there can be these episodic spasms in addition to this generalized increase in muscle activity. And this is an autoimmune disease, and it's associated with several antibodies, as you mentioned, anti-GAD, which I think is it glutamic acid decarboxylase? It's something in the GABA pathway. Someone can tell us in the chat what the G, it's something something related to glutamate. I forget what the exact.
Glutamic acid decarboxylase.
Glutamic acid that was, yeah, decarboxylase. And so by decreasing GABA through whatever mechanism, then you're decreasing inhibition and increasing activity. And then anti-glycine and anti-amphiphysin. And some of these are paraneoplastic. So if you do think this could be the diagnosis, you want to evaluate for the possibility of an underlying cancer. Do these patients typically get myoclonus, Yasmin or Sridhara, patients with stiff person syndrome?
Not usually. It's hard to see the movements these patients are having. You put a needle electrode in the EMG, you see the abnormal movements, but it's very hard to see the kind of myoclonus you expect to see from other conditions.
Yeah, like as far as I remember, the stiff person syndrome, there are many classifications, which are the classic SPS that you can find the anti-GAD antibodies, etc., etc. There are variants of it, and there is I think I also saw it in the chat, the PERM, which, if I'm not wrong, is progressive encephalomyelitis with rigidity, and I forgot myoclonus, the M. So there is this variant, of course, of stiff person syndrome, which basically, as its name suggests, stiffness and myoclonus.
Yeah, and the key feature is
yeah,
those patients are prone to sudden, if you walk into the room and you clap your hands really loud, they have these sudden myoclonic jerks. It's very, very classic, and you will never forget it if you see it.
Yeah, excellent points. Yeah, so I don't think the classic stiff person syndrome has myoclonus associated, although the muscle jerks that the patient's describing could just be something in the spectrum of cramping and spasm. But yeah, there is on the stiff person spectrum of conditions, this condition PERM, as Yasmin mentioned, progressive encephalomyelitis with rigidity and myoclonus, which is a sort of very extreme version of this condition, extreme in the sense that it's severe, and then there's other signs of hyperexcitability, including myoclonus. Excellent. So we all seem to be talking a lot about this, which is going to make us anchor in that direction. Is there anything else that could really cause 10 years of progressive muscle stiffness, spasms, to the point that the patient is falling and getting hospitalized related to muscle spasm?
Well, my neuro DDX now could be any myelopathy, could be compressive, an inflammatory cause. And I'm really not infectious, because I think infectious would definitely present as acute or hyperacute, and also myopathies and muscular dystrophies. And there are also autoimmune conditions, autoimmune encephalitis, or any other if I'm like adding to that DDX any hereditary conditions, such as like spastic paraplegia. I think there is a hereditary spastic paraplegia, but I think that maybe this could have presented way before. But I would definitely like to ask the patient if this was always intense, or it started progressing from like maybe just jerks in one arm to the leg, or how did it progress? If it was always the same, or if it started getting worse with time.
Yeah, excellent. Excellent. Other thoughts, Sridhara?
Yeah, I mean, the differential that Yasmin said is amazing. And I would keep the differential just because even though neurology history is the key, sometimes, when muscle spasms are the main complaints, the patient just might not be mentioning the other stuff, which might be seen on exam. There might be hyperreflexia, there might be sensory loss, there might be other things that localize to spinal cord or other locations like, myopathy or something. So yeah, so I would still wait for the exam before we kind of crystallize our diagnosis and our differential.
Absolutely. Yeah. So myelopathy, Yasmin, thinking of this because of could the spasms be spasticity? We're not hearing about weakness, sensory changes, bowel bladder, other things to go along with spinal cord, although maybe the spasm is such an overwhelming symptom in the patient's mind that they're not reporting some of these other symptoms, at least on the first pass of the HPI. Probably the only other thing to think of without seeing the exam is myotonia, which can be an increase in muscle contraction. And what conditions can cause myotonia? Well, the classic that most people know is probably myotonic dystrophy, which is a inherited myopathy that has this additional finding of myotonia. So there can be grip myotonia when you shake the patient's hand, they have trouble opening the hand. You can get percussion myotonia where you tap the thenar eminence and the thumb comes up and then sort of stays there. This patient is not describing weakness or any of the other features of myotonic dystrophy, but you can get myotonia in other conditions. There's a rare, I think usually paraneoplastic condition called Isaac syndrome, which I haven't seen before, but is associated with antibodies to Caspr2, which were previously called voltage-gated potassium channel antibodies, but it's a subclass of those antibodies more specifically that can cause this myotonia, myokymia, I believe also other findings in the muscle. I'm not sure actually if these patients present with spasm, cramping, or since I haven't seen a case, I've only seen it in the literature. And then there's a sort of correlate of that Isaac syndrome, I think with the same antibody called Morvan syndrome, where it's these peripheral findings as well as encephalitis also. So maybe something else to keep in the differential we try to see on the physical exam, is this muscle spasm or is it myotonia, myokymia, spasticity? Are there other associated findings? So great discussion, and this gives us some hypotheses to test as we go into the physical exam. Tansu, anything we should be aware of in the past medical, meds, family history, social, etc.?
Before going there, just to answer some of your questions, it was always prominent on the left side, her symptoms, and they weren't exacerbated by exertion. She actually had extreme anxiety about mobilizing. So I just wanted to add these. And so I can go on to vitals. So unfortunately, I don't have access to full set of vitals, but according to what my friend told me, no abnormality was noted in the vitals. And then in the general exam, she appeared anxious. The review of systems was negative. Her heart, lung, and abdomen exams were benign. In the musculoskeletal exam, she had no synovitis, no effusion, tenderness to palpitation of any joints. But the musculoskeletal exam was notable for stiffness of abdominal and paraspinal muscles. The range of motion was hard to assess on the left side because of the patient's inability to flex her extremities. It was limited by pain. And in the neurological exam, her mental status was normal. She was alert and oriented, normal cognitive function. Her cranial nerves were normal. She didn't have any speech or swallowing difficulties. And then her motor strength was 5 out of 5 in the right upper limb, both proximally and distally. And in the left upper limb, it was 4 out of 5 proximally and 5 out of 5 distally. In the proximal and distal lower limb muscles, the strength was 5 out of 5 and 4 out of 5 in the right lower extremity. She had difficulty flexing her hips and knees, and she also had difficulty bending at the waist. And her reflexes were all normal. She had brisk response on the reflexes. Her plantar response was normal, Babinski negative, and her sensory exam was also normal. No sense of smell deterioration or no urinary or bowel symptoms. And cerebellar exam was also normal, and she just had slow gait, and it was hard to ambulate without support. And she ambulated at the hospital holding the rails, the side rails. And then in the family history, the patient didn't have any family history of neurological disorder. Her past medical history was significant for deep vein thrombosis that was unprovoked, and hypertension, chronic pain syndrome, and fibromyalgia. And in the social history, she didn't drink any alcohol, use any other substance, and she was a non-smoker. She didn't have any allergies, and I can tell you her medications as well. Yeah. She was on apixaban, omeprazole, baclofen, amlodipine, gabapentin, and losartan.
Okay. Yasmin, Sridhara, what are we going to do with all of this additional information? What we found on the exam, and then this past medical history, medications, etc.
For me, like I'm really trying not to anchor, but taking a step back on this patient, 54-year-old woman with stiffness, axial and limb stiffness of abdominal and paraspinal muscles, and with also a past medical history of fibromyalgia, makes me think, what if, obviously fibromyalgia is a very difficult diagnosis, but I would definitely want to know if this was not basically the start of an autoimmune issue, such as stiff person. That's why I said I didn't want it to anchor. But this kind of, it's associated with that. Like there are even papers that say that fibromyalgia, chronic pain syndrome, and other pain diagnosis can be confused with stiff person. That's why it's very difficult to diagnose. What do you think, Sridhara?
To me, the physical exam kind of helps rule out other diagnoses. You know, the fact that mental status is normal makes accompanying encephalitis less likely, autoimmune encephalitis. The cranial nerves being normal and the muscles of swallowing and all these other things being normal, and lack of much in the strength being pretty good in the upper limbs, and the reflexes being normal. So all these things take away from the other differential and kind of help us narrow down towards stiff person syndrome. So yeah.
Yeah, I agree completely with both of you. There were other things that were still kind of on our minds that we wanted to figure out on the physical exam. Are there any upper motor neuron signs to suggest that some of this could be spasticity? But with normal reflexes and no Babinski, we can take that off the table. Hard to know what to make of this proximal weakness. If the patient has a lot of pain or spasm, they may have trouble. Participating in the motor exam, and it can be very hard to interpret in that context. And one thing I like to do is sometimes the resident will come or the student will come and tell me the patient has 4 out of 5 weakness, and maybe we're not expecting that, or it doesn't fit with the rest of our hypothesis. And we want to double check whether they truly have weakness or it's sort of pain limited. And so when I check in patients who have what's sometimes called giveaway weakness, which can be from pain or fatigue rather than true weakness, I'll ask the patient, I'll put my hand on the muscle I'm testing and say, on the count of 3, I just want you to give me your full effort, even just for a second. Ready? 1, 2, 3, go, 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 and have some direct downward force or force against the muscle. And just for an instant, see if I think I'm getting full strength and then it's fatiguing or giving way. It's a little bit subtle, and you want to be careful of confirmation bias there if you're not expecting the patient to be weak, or it doesn't fit, or you have, as you said, Yasmin, this patient with chronic pain and fibromyalgia. Maybe you might think this is going to be pain limited based on that past medical history. You don't want to miss that there is some weakness, but that can be one way of trying to get a sense of, is the first impulse full strength or not. Okay. And so otherwise, what do we see here? We see actual stiffness and spasm of abdominal and paraspinal muscles. And as both of you said, there's not too many things that could be doing that aside from stiff person syndrome. And so one wonders, as you said, Yasmin, is some of this fibromyalgia or chronic pain, are these misdiagnoses of what has always been stiff person syndrome? That's a very important point. And this patient's receiving medications for pain and muscle relaxation, baclofen, gabapentin, that, at least as far as we've heard, have not seemed to have an effect, as I think was mentioned by Sridhar, that diazepam, benzodiazepines are the appropriate treatment for this condition. And patients can be on very high doses, actually impressively high doses. It's not clear to me anyway how they can remain awake on such high doses, that somehow the physiology and pharmacology of the muscle seems to just be taking it all up and using it to treat the stiff person syndrome at doses you would think would normally be very sedating. I was intrigued by this unprovoked DVT, given that this can be apparent neoplastic syndrome. Are those two related? And is there some underlying malignancy that has led to both hypercoagulability and this immune-mediated neuromuscular disease? Actually, well, I was neuromuscular in the sense that it's affecting the muscles, but neuromuscular would usually refer to a peripheral disease, and this is actually due to the decreased GABAergic transmission, which I believe would make it technically central, although I'm realizing I don't fully understand the pathophysiology of this condition. Okay, so if our hypothesis here is stiff person syndrome, are there any tests we would want to get at this point to try to confirm that diagnosis?
Yeah, if we are thinking of stiffs, I would definitely ask for NT-GAD, because it's basically presented like, I'm not sure of the percentage, but I remember it was very high. Also EMG, electromyography, and and also other antibodies, TTP and TGO could be there. And if we find so, we will be looking in, if we find these antibodies on the CSF, I believe that the algorithm says that you also have to look for them intrathecally. And but I do have a question, like taking a step back before anchoring again on stiff person, like could we try to localize where the issue is? Could it be because all these issues are motor? I don't see, I said sensory is normal, reflexes are normal. Could we try to characterize this as an issue on nerves versus muscle? And if so, is there any lesion on the corticospinal tract, which is the one that takes care of the spasticity? Like if there is a damage in it, there will be spasticity. So I don't know what you think.
Yeah, go ahead, Sridhar.
So if the cortical spinal tracts are involved, the expectation is we see hyperreflexia and Babinski. The fact that you see normal reflexes and downgoing toes tells us that it's unlikely to be the corticospinal tract. And to your point, when we test for antibodies, you want both serum and CSF because some of these antibodies are more sensitive in the serum and some are more sensitive in the CSF. And we have tried to move away from testing one specific antibody to doing more of a panel because these conditions, the spectrum is just expanding. The other day, we had someone who had a glycine receptor IgG that had stiff persons, and the GAD was negative. Amphiphysin, DPPX, there's few other antibodies that are starting to show the same manifestation of stiff persons. So yeah, those are my thoughts.
Yeah, excellent. So yeah, I agree. There's not too much going for corticospinal tract here, though, as you said, Yasmin, certainly something we would want to think about, given whether the spasm could be spasticity. There's no other clinical signs pointing us in that direction, although if the patient is really stiff, it might be hard to get a reflex if the muscles are so stiff that they're impeding the reflex. So one could wonder if those 2+ reflexes in the setting of a lot of spasm are impressive rather than normal if they're being generated through a lot of restriction through spasm. But then you probably think there should be some upgoing toes, and if this is really years and years of a progressive spinal cord syndrome, we would probably expect some sensory and bowel and bladder to start coming into the picture as well, which we're not hearing. So it does sound like muscle spasm, does sound like stiff person. And so the diagnosis is really made by antibodies, as both of you said. Now, anti-GAD is a complicated one. It can also be seen in diabetes type 1, which this patient does not have. And when we send antibodies for syndromes that have a larger array of possible antibody causes, for example, autoimmune encephalitis, when we're looking for it can be NMDA, GABA-A, GABA-B, anti-HU. There's a whole list of antibodies that can do it. We're sending these panels. Anti-GAD is one of the ones that often comes back slightly positive and is not always relevant. So it's important to look at the titer because it's often an irrelevant false positive. And so sometimes patients are worked up for autoimmune encephalitis or autoimmune cerebellar degeneration or something. They may have that syndrome, or in some cases they don't, but people are sending antibodies and you get a GAD back and people attribute a little bit too much to it. The patient's on immunosuppressive or immunomodulatory medications that they don't actually need. So you do want to really correlate the GAD with the clinical syndrome and make sure it's a titer that is considered high enough to be causative, because you can get these sort of low false positives that are of limited relevance. Very interesting and well done review in the past year in JAMA Neurology about misdiagnosis of autoimmune neurologic conditions, and one of the culprits is overinterpretation of a anti-GAD antibody. But in the appropriate clinical context, if person being one, I think it can also do cerebellar, immune-mediated cerebellar degeneration, probably some others, and a high titer, then it might be causative, but you want to be careful with that one. And then it would just depend on your institution and your lab. Are you allowed to send all these expensive antibodies, which usually send out tests, or would you start with anti-GAD? And if it's negative, then you could make a case for sending anti-glycine and anti-amphiphysin antibodies. There are classic EMG findings of motor hyperexcitability in my experience, but the few cases of this that I've seen, which is not very many, is that usually don't need that. It's pretty obvious clinically. And then you can see inflammation in the CSF on lumbar puncture, but again, with a classic clinical syndrome and with an antibody, I'm not sure you need to do that. And I was thinking when you made that point, Sridhar, about serum and CSF antibodies, what you said is completely true, that some conditions, the antibody is more specific in the serum, such as LGI1 antibody encephalitis, and some it's more specific in the CSF, such as NMDA receptor encephalitis, sensitive and specific, or certainly specific in the latter, and I think sensitive in the former for LGI1. But this is a rapidly evolving field with lots of antibodies. But I'm not sure in this case if you need CSF antibodies. Maybe you've come across this in the literature, or if you can make the diagnosis on serum alone. I think that you can, but I may be mistaken on that. And also, it's just logistically a very hard lumbar puncture to do if there's a lot of axial spasm. It's very hard to position the patient and get your landmarks and do a lumbar puncture if there's a lot of spasm of the axial musculature, hard for the patient then to sort of roll into the fetal position and open up the space between vertebrae to put your needle in. So I think this is a clinical diagnosis plus antibodies, and probably the only other test I would think about here, which was not mentioned, was a CT chest, abdomen, pelvis, or a PET scan to make sure there's not underlying malignancy. And in paraneoplastic neurologic syndromes, they can actually be the heralding feature of the neoplasm. It's thought maybe that some of these neoplasms are triggering an immune response against the tumor, and that the autoimmune neurologic syndrome is sort of, well, not just it is thought, it is, I think, considered scientific fact at this point, that the immune response against the tumor, the sort of friendly fire, generates these autoimmune antibodies. What I was going to say is it's thought, and I believe there's some evidence to support the fact that part of the reason some of these patients are presenting early, before there's a known cancer with the neurologic syndrome, is that the immune system is appropriately taking care of the cancer through immune surveillance. It's found far in tissue and it's eliminating it, and the extent of that response is causing this extra immunity against the body. And I mention that because it is recommended, if you see a classic paraneoplastic syndrome, like paraneoplastic cerebellar degeneration is one important one, and you find appropriate antibodies, and they're ones that have a high association with cancer, and you do a PET scan and you don't see anything, it's recommended to continue surveillance with PET or CT chest, abdomen, pelvis every 6 months for a few years. Lambert-Eaton would be another one, for example, very high association with malignancy, because sometimes the cancer can be so small because the immune system so effectively dealt with it, although at the expense of the autoimmune neurologic syndrome, that it might not be detected on initial testing, and the patient may have the neurologic syndrome for months or years before the cancer is detected. The idea that she had this for 10 years probably means there's not an underlying cancer, although maybe early on the symptoms were some type of other chronic pain syndrome, such as fibromyalgia, and the stiff person is a more recent part, and for the patient it might be hard to distinguish what began when and which symptoms are attributable to which. So I would say starting with an anti-GAD, and if negative, anti-amphiphysin and anti-glycine antibodies, and then a CT chest, abdomen, pelvis, or a PET to look for malignancy. As I said, there are EMG and CSF findings you can see, but I'm not sure they're required for the diagnosis if you have the right clinical story exam and antibodies. And while you're waiting, because those antibodies take a while to come back, how would you empirically treat this patient?
For STIFs, the first one is benzodiazepines, dantrolene, and baclofen. And that's basically, but she's already in baclofen. Although Dr. Sridhara in the chat told me that if she was given benzodiazepines and she didn't answer to the treatment, that would put us away from it. Although that's what I would start.
Right. Yeah, that's right. So I think diazepam, benzodiazepines are the first line treatment. And so for the patient's relief of their symptoms, and in part as a diagnostic test as you're looking at the therapeutic response for diagnosis. So sometimes therapy is diagnosis. So while we're waiting for these antibodies to come back, starting some diazepam while the patient is in the hospital and titrating it up to response. So what happened next, Tansu?
Great thoughts. So as Dr. Berkowitz, as you said, paraneoplastic workup was done and all the antibody workup was negative. And she was assessed with CT of the abdomen, pelvis, and chest, and mammography. And these didn't reveal any signs of malignancy. And then her antineuronal antibodies, anti-physin, GABA A, GABA B, glycine antibodies were checked, and those were negative, but anti-GAD antibody was positive. And the titer was more than 2,000. And then the diagnosis was made eventually.
Yes, I think the diagnosis has been made by Yasmin and Sridhara and confirmed here by the testing. But tell us what happened next for this patient, Tansu, how they were given the diagnosis and how they were treated and how they did, and any other teaching points you have about stiff person syndrome you learned in preparing this case.
So she was followed up as a functional neurological disorder case for 10 years. And she was given all the medications for her working diagnosis. But after the actual diagnosis of stiff person syndrome was made, in order to achieve the rapid decrease in the anti-GAD antibody titers, PLEX was done. And then with the support of the physiotherapy, she was able to become ambulatory again, and she was started on a trial of benzodiazepine, and her symptoms improved significantly. And then IVIG infusion was started subsequently, which also contributed to her recovery. What I learned from this case is when a patient has such symptoms for such a long time, for 10 years, it's good to do the workup all the way and not just conclude at the functional neurological disorder. So all the workup should have been done in the first place before concluding too early as functional neurological disorder for this patient. Also, something so interesting from the standpoint of internal medicine for me was, as you mentioned, GAD wasn't only found in GABAergic neurons, it's also found in pancreas, and type 1 diabetes can coexist with stiff person syndrome. So this was an interesting thing that I learned from this case.
Fantastic. Wonderful case presentation, Tansu, and thank you for also letting us know what happened to this patient. Trying to remember the last time I had a patient with this and looked this up, what the story is with when to initiate immunomodulatory therapy. I think that if the patient is very responsive to benzodiazepines and there's a full response, you can follow them. But if they're not responding completely, or the disease continues to require escalating doses, or you hit side effects, that is when you would initiate. I believe it's usually IVIG, sort of monthly IVIG, and then over time, if the patient has a good response, try to space it out, and see if the patient still needs it or their treatment can be symptomatic with benzodiazepines. Did you see, Tansu, or do you know, Sridhar or Yasmin, if all of these patients need to get IVIG or plasma exchange from the beginning, or if you can? I thought I had read at some point, although I could be wrong, that or could be misremembering, that if you get a good response to benzodiazepines, you don't necessarily need immunomodulatory therapy. Anyone know the answer to that?
Yeah, like the treatment starts with benzodiazepine, although the patient can start developing this unresponsiveness. That's when you take a step further and use baclofen. But I don't remember if it's the VIA, because I don't remember it's not oral. The thing is, you can use baclofen and also use muscle relaxants if it's the macron is very prominent, the cramps are very prominent, the spasms, sorry. And the IVIG is only for specific cases where nothing else is helping the patient. And even if IVIG doesn't work, you can start with immunomodulators.
Got it. Yeah, is that your experience as well, Sridhar? Some patients might get a full response from benzodiazepines, or does every patient ultimately need IVIG?
Yeah, so most patients, they do respond to benzos. The problem is, like Yasmin pointed out, some of them stop responding, and those are the patients who need immunomodulatory therapy.
Yeah.
The other thing also is there is some correlation to titers. When we see titers like more than 500, those are the patients in whom, I anticipate some requirement for immunomodulatory therapy. And GAD65 can cause the other manifestations like ataxia and stuff. Those patients also, they tend to more often require immunotherapy. They need first line immunotherapy. And then most patients tolerate benzos well, but some just cannot tolerate the meds. And again, that's another population where we tend to go towards immunotherapy sooner. And I put this in the chat, but if you do GAD65 after giving IVIG, you'll get a low titer that's positive. So it's a pitfall that does happen sometimes.
You mean that the IVIG will give you a false positive GAD, or it will lower the? Yeah.
It'll give you a false positive, low titer GAD positive. So, it's just a false positive.
Yeah. And yeah, very important point. So it sounds like we are all thinking / all have read or heard the same thing, that some patients will be sufficiently benzo responsive that they might not need immunomodulatory therapy, but if they are not sufficiently benzo responsive, or the benzo dose is so high that it can't be tolerated due to side effects, those are patients in whom you'd want to think about immunomodulatory therapy. Yeah, this is a legitimate GAD titer over 2,000. The ones you want to watch out for, it depends on the scale, is where it comes back positive, and it might not correlate with the syndrome, or it's not as impressively high as this. I'm not sure there's a clear cutoff, but there's like I said, a nice recent paper in JAMA Neurology on misdiagnosis, I think specifically of autoimmune encephalitis, and how the patients, when they got to tertiary centers and were correctly diagnosed, why they were misdiagnosed. And one of the culprits, if I'm remembering correctly, are these overinterpretations of low positive GAD titers. And so it's a good point. Some patients are presumed to have an autoimmune disease. They get IVIG. And remember, IVIG is the pooled serum of countless people, right? And all of their IGs, right? And some patients are walking around with these false, well, not false, yeah, are walking around with GAD antibodies from diabetes type 1, or they just have a little GAD antibody. I don't know why people produce this antibody, but you have to be a little skeptical of the titers of antibodies after IVIG, since IVIG is IGs, right? It is antibodies. Well, phenomenal discussion, everyone. Thank you for presenting the case, Tansu. We have 3 minutes. Bettina, do you want to give us some of your favorite teaching points from this case? I see you have a lot. You keep making everything else smaller. That's how we know we've had a fun session today.
Yeah.
And so if you want to give us for a few minutes some of your favorite teaching points from the case.
Definitely. Thank you so much for the incredible case, Tansu. So just a couple of important teaching points that we have. First, we talked about muscle spasms. And what's important when we think about muscle spasms is to define it, if it is a true spasm or not. It could be weakness, it could be a sensory issue, it could also be due to radicular pain shooting down to the leg. It can be muscle cramps, spasticity, fasciculation, seizures, and dystonia. So it's so important that we are able to define the muscle spasms through the history and then confirm later on with the physical exam. And then a lot of our discussion centered on stiff person syndrome, and there are a lot of teaching points here. So first is that we check for the antibodies like anti-GAD, anti-ampifysin, anti-DPPX. We also check the oligoclonal bands, use an EMG, and of course a CT chest of the chest, abdomen, and pelvis, and a PET scan. And we are thinking of a paraneoplastic syndrome for this. So also important is that when we give IVIG, which is sometimes we do when we consider an autoimmune disease, it can affect the antibody titers later on. And then another important point is that the treatment for stiff person syndrome is with high benzodiazepine doses, which is the first line. And if the patient is not responding to it and to escalating doses, we can initiate monthly IVIG that we can space out over time. And then later on, we can also consider immunotherapy. And immunotherapy is something that we can consider early on if the patient presents with ataxia. And then very important in our case, especially, is the history of unprovoked DVT, which can hint us to malignancy. As stiff person syndrome can present as a paraneoplastic syndrome, as I mentioned earlier, due to the immune response against the tumor. So if the patient ends up having a negative PET scan, surveillance is very important every 6 months to 1 year. So that's it for the teaching points for today.
Fantastic synthesis and great teaching points, Bettina. And I'm trying to remember, do you know, Yasmin or Sridhar, anti-GAD, I think, is one of the ones with a lower correlation with an underlying cancer compared to ampifysin and glycine. So there's this whole field of autoimmune neurology, which has really emerged in the last 15 years or so, very exciting area of neurology, both for diagnosing new diseases that were previously there, but nobody knew what they were. And also often these are quite treatable. So when students ask, is neurology too depressing and all these sorts of things, right? I often try to make some of the points of, well, one, that all of medicine is depressing, right? People are sick. And so not sure why neurologic disease is more or less depressing than renal failure, cancer, et cetera. But on the positive side, right, there are a lot of conditions we can treat. And I often find it amazing that we have new diseases. Lots of specialties have new treatments coming out, but very few specialties, I think, can say we have recognized brand new diseases. And they're diseases that we hear about, read about, and then we see. So this whole area of autoimmune neurology, one of the leaders is Josep Dalma, who's in Spain. And then the Mayo group has a lot of autoimmune neurologists also who found the antibody for neuromyelitis optica, which I think we've discussed before, aquaporin 4, and many of these other syndromes. And so the antibodies are divided into two categories: cell surface antibodies, like anti-NMDA, that's actually an antibody against the NMDA receptor, and intracellular antigens, like anti-Hu, which is also called ANNA1, anti-Re, anti-Ma, anti-Ta. There's all these antibodies that have these sort of initials, I think, of the index patient, if I'm not mistaken. And then there's the cell surface, which have the names of receptors you'll remember: anti-NMDA, anti-GABA-A, anti-GABA-B, the voltage-gated potassium channel ones are now LGI1 and Caspr2. So there's this whole list. And the major, or sort of, how can I say, the general rule is that the cell surface antibody ones generally respond very well to immunotherapy, and the intracellular ones often do not. So for example, the paraneoplastic cerebellar degeneration ones are often caused by intracellular antigens that actually cause death of the Purkinje cells in that layer of the cerebellum. And so even if you can stop the process, you've lost neurons. And then the intracellular antigens have a higher association with underlying cancer, and the cell surface ones have a lower association. Doesn't mean no association, but to that last point of screening for paraneoplastic conditions, there are some where the proportion of patients who end up having an underlying cancer is so high that you have to be very diligent, whereas others, it's relatively low. And so you, if you don't find it, it can be okay to stop looking after a certain period. NMDA is interesting because it has a high association with ovarian teratoma, and the immune response against the teratoma that's expressing this NMDA type antigen that leads to the condition can sometimes be so well dealt with, so to speak, by the immune system that there's nothing visible on imaging. And there are cases reported where the young woman is getting progressively worse despite therapy, and no one's seeing a teratoma, and the difficult decision is made to do an oophorectomy in spite of that. And then on pathology, it is found that there's a very small cluster of teratoma cells. Colleagues and I published a case actually with someone, I think from medical ethics, about a young woman who developed NMDA receptor encephalitis, and had no obvious teratoma, but was very, very ill, and very difficult decision with her family, despite being a young woman, to think about oophorectomy in her case. And it did save her, but then she unfortunately had both ovaries removed as a result. So very complicated case with commentary from ethics and legal folks, if you're interested in looking that up, probably around 2015-ish. I forget which journal. And I was thinking of something else, but I forgot. Does anyone know, Sridhar, Yasmin, or Tansu, or others? The anti-GAD, I think, is not zero, but relatively low association with underlying cancer, but I'm not sure.
It's lower correlation, but the patients who present with the encephalomyelitis and epilepsy, they tend to have more association with the cancer than the patients who present with stiff person or ataxia.
Interesting. So depending on the GAD-associated syndrome, the association is higher. Yeah, we had a case where a guy actually had a very interesting gentleman, I think in his 80s, that was involved in some type of Olympics for people of that age, and was actually a very sort of elite octogenarian athlete who developed freezing of his gait. It looked very Parkinsonian. This case, I know the resident published because her paper won an award we published together. It was anti-GAD, and we went through sort of the spectrum of all the things GAD can do. It can cause stiff person, it can cause cerebellar syndrome, and I think we found in this case it can cause primary freezing of gait as well, which has its own differential. The first author is Sheena Chu, probably around 2016, in neurology. So these are out there, but they're uncommon, and they have a lot of these antibodies. Another principle to be aware of is some of these antibodies have a very specific syndrome, and NMDA encephalitis presents very similarly patient to patient, and a very specific cancer association, whereas some, like anti-Hu, can cause encephalitis, can cause neuropathy, can cause ganglionopathy, and can be associated with small cell lung cancer, any number of cancers. So there's all these sort of not one-to-one relationships. One antibody that can cause multiple syndromes, one syndrome that can be caused by multiple antibodies, one cancer, small cell lung cancer, that can be associated with a lot of antibodies, or some types of antibodies that can be associated with multiple cancers. Okay, well, that was a great case, Tansu. Thank you, Yasmin and Sridhar, for your expert discussion, Bettina for your teaching points, and we will see you again in a few weeks. Have a nice day, everyone.